Hi everyone. My name is Suraj. I'm a student of the Center of Doctoral Training, so one of the ones that we have in Bay Campus, and we focus on in human-computer interaction and embedding the human in the decision taken by an AI system. So currently, my project is with Amicus Therapeutics, and they are an organization looking for cures to rare diseases, treatments essentially. My project is based on understanding rare disease biomarkers by applying AI techniques to it. And as you may have seen before, a lot of the uh, rare diseases currently use, so a lot of the clinical data sets that we have currently consist of imaging data from ultrasounds, x-rays, CT scans, MRIs, and they prove to yield very similar diagnosis to error rate, to that of clinicians. Face2Gen is one of these examples, and it can assist physicians in diagnosing rare genetic skin-based diseases or conditions based on photographs of the patient's face. The current pandemic has led to a need and demand for more augmented clinical decision systems. So now this is what we term as emergency ML. Uh, throughout the patient care way, throughout the patient care way, pathway, there are opportunities for these ML support decision systems to collect vital laboratory results, medication orders, comorbidities, and with this rapid age where we are collecting more of that data and making it available to the researchers, we want to focus on essentially transferring and developing these ML techniques to match that data collection and the inherent nature of healthcare data. In this case, I try to understand what the kind of literature is there around ML techniques in rare diseases, so in essentially a rare event case scenario. And there's a lack of literature in this area, with only 200 papers actually being released conducting specific ML techniques in AI and rare diseases. Um, in this area, we found that there is lysosomal storage disorders are currently underrepresented, and there is hardly any research applied to diagnosing Fabry, which I'll present right now. And although I'll put this into context, there are over 7,000 rare diseases, and only an estimated 5% of these rare diseases have treatments. And many of the patients that actually come in with a rare disease take an average of 8 years to get diagnosed, with many of them having several misdiagnoses or going undiagnosed for a long time. So with Amicus, they work mainly on lysosomal storage disorders, one of them being Fabry, which was the aim of my project. Uh, Fabry essentially manifests a series of different symptoms or manifestations, uh, including the ones as follows. Many of the more predominant one are pains and nerve endings. We'll have dark patches called acroparesthesia. You'll have eventually notice episodes of kidney problems or heart problems because of the buildup of fatty acids in these vital organs. Essentially, what we refer to as fats is GB3 in this case. This condition can have apparently take an estimated 15 to 20 years to actually diagnose. So patients will traverse from a series of different clinicians sometimes up to 8 different clinicians, these including both primary and secondary care physicians. And they can be diagnosed with conditions like rheumatological disease, arthritis, or neuropsychological diseases. The focus of our study was to look at biomarkers such as GP3, lyso-GP3, and T1 mapping specific to the heart and the thickness of the wall. These essentially are areas, the lyso-GP3 and GP3 are the chemicals that build up within the surface, within the inner layers of these organs. And the T1 mapping is, as we understand currently, is reduction, the thickness of the heart increasing due to this buildup of fatty deposits. Currently, many of these biomarkers have shown some correlation or evidence of diagnosis of Fabry, but there have been instances where we've noted that these biomarkers alone are not enough to actually indicate the presence of this rare disease, and they require genetic testing to confirm. So, as I've explained, there is a rarity in data samples available for this condition, and due to this, we come to the actual focus of the talk today, which is developing a technique developing a technique for rare event detection with a data set that is publicly available. So we chose sepsis simply because it has got the strong foundation of research behind it, as well as the public available data set. The data set is structured in a way where each patient has a series of ICU hours, and the final outcome of the disease, if not treated, can end up being multisystemic organ failure and death, which can many times occur within a few set of hours. Many of the ML techniques, as I described before, a range of them have been applied from decision trees to neural networks, many of them being successful, but not overly, as I will show. And there's an insight platform, which is currently reducing the mortality rate of sepsis patients by 40% and helping clinicians detect these events earlier on. And our focus is to extend these techniques as well as extend the build approach to actually modeling this imbalanced data set. So initially, we found that, as with many healthcare data sets, we come across the problem where there's a lot of data missing. A lot of data is actually not missing at random. So this is as an example, we can put this a lactate score taken every 6 hours instead of hourly due to the pathology laboratory requiring a larger amount of time to test the sample, or due to the inherent non-requirement of actually monitoring the sample over such a short period of time. And many of these clinicians assess the patient's status through what we understand as clinical scores. So the SAIS is a systematic inflammatory response score. Generally, how the body's inflammatory system, so the immune system, is responding to an infection. So sepsis is a bacterial infection and generally causes an immune response. Then we have the SOFA score, which is a sequential organ failure score. This is a general score which indicates how each organ of the patient, so respiratory, kidney, is evolving over time, and if it is actually prone to failing, and how prone is it. These are all the kind of scores that we wanted to embed into our data set to help the algorithm formulate a more informed decision. The way we essentially tackled these missing values as well as the randomly missing values was through interpolating. So essentially, we fed forward all the values that were present, as to not, we didn't feedback as to not allow for any events to be interpreted earlier than they actually occurred. And we also created a new imputation system, data filling in system, which was more specific to the healthcare scenario in place. As you can see, this is just the heart rate and how we were missing a few variables, just added a point in the middle and combined the data. A bit more on that data processing side, so calculating things like the mean arterial pressure. Both, there was an instance where there was availability of two variables, but then the third one wasn't present. So um, simple equations would suffice in some cases, whereas sometimes we actually had to go and exclude some of the variables that were missing, up to 100% of the values. Surprisingly, don't even know why they included it. And then, as they said, they can customize imputer, so data filling in strategy, which required us to filter out and group sets of patients. So we took samples from the data set and looked at a certain age range with a certain diagnosis and a certain gender, and we looked at how much data they had filled in, took that data, averaged it out, and then filled in our missing gaps essentially. So this is similar to what we know as a k-nearest neighbor imputer, but with a little less complexity. We then converted the data into a form which was readable by our temporal learning deep neural network, essentially just an AI model. Um, One of the first stages of this is to understand, to input into our AI model, is the requirement of actually having the data of the same length. So essentially, we could batch them up. And we knew that many of the patients were coming in and leaving at very random hours. So it's 96 hours. Some patients could have 10 hours in ICU. Some patients could have 330 hours. So it required this model of padding and masking, which is essentially just adding zeros at the end of the sequences to make them all have the same sequence length. This allows us to feed in the data to a model and learn that that set of sequence is essentially a patient. We also apply a masking layer within the model, which just helps the model. It's funny that it actually helps the model forget that, understand that these layers, these padded sequences must be forgotten and just concentrate on the actual data. We then went on to include two LSTM layers, long short memory layers. This is essentially just an AI, two AI layers. They have four different stages. The forget layer is basically the one that takes the data from the previous layer and just throws away some of it. So it forgets it, as to sometimes not create a very strong pattern, but infer a more trial and error based pattern. Then we have the input gate layer, which takes the new input that comes in from the next hour of the patient and models it and adds it to the previous kept data. We have an updated cell state, which is essentially how we update our weights within the cell, which then all get concatenated into filtered output, which is the next input for the next cell. So there's, in each of these layers, there's over 200 of these tiny structures, essentially, these LSTM nodes or mod, yeah. And we have two structures feeding into each other, so over 400 different combinations. We also add this batch normalization parameter, as you'll be able to see. This essentially just allows us to speed up the training. It's essentially or the time it takes from a model to converge from outside the center of the minimum point may require thousands of iterations, but if we normalize this data, we minimize the number of iterations required and speed up the time it takes to train. We then went on to include these time distributed activation layers. These are simply layers which reduce those 200 times 200 neurons into an output which we can read. So something like a set of probabilities of there being a diagnosis at that certain time. So time distributed just meaning that there's sequences being output by the model, which are just sequences of diagnoses. Um, and these layers provide us with a means of reducing that information down into the essential bits. We also implemented two different structures of the algorithm. So not only concentrating on and leveraging on the fact that we have two LSTMs, because we're learning a complicated temporal sequence of events. We also wanted to see how the model modeled it in a simple one-layer LSTM. But aside from that, the focus of essentially creating this model, apart from it being a very off-the-shelf model, was to actually implement certain loss functions, essentially how the model updates itself towards the right diagnosis, and trying to have these loss functions actually mimic the correct function, the correct pattern there was to a sepsis diagnosis. So sepsis patient, yeah. One of them was a sparse categorical cross entropy. Simply, this measures the dissimilarity between the distribution of observed diagnoses and the predicted diagnoses. We then moved, these are very standard off the shelf. We then implemented a weighted binary cross entropy, which is a binary cross entropy, essentially the same dissimilarity between distributions, but with a focus on actually understanding, allowing the algorithm to make more false negatives, essentially make more false negatives and less false positives, essentially not over predicting sepsis. So, not overly tagging patients that were not septic with sepsis, as the focus was on reducing the number of errors generated by it, but allowing it to not predict sepsis as early, still penalizing it to predict it. The same applied with mean squared error, simplistic error, as we wanted to reduce the time runtime on the model, but we wanted to still try that weighted aspect. And then a final one, which is the sparse categorical focal loss. So as the for categorical cross entropy, it models the dissimilarity between both class label and probability, but puts a focus and weights heavier the actual samples, which are harder to classify. So those closer to the 0.5 probability for both 50-50. We then also model the evaluation of this model with a clinical utility score. So this essentially puts more of a weightage on early diagnosis of sepsis, and then as the diagnosis time reaches it's the highest weightage, and as it goes past that, it reduces the weightage. All other samples are modeled differently, as you can see in the graph on the right. Then we also adhered to essentially what is imbalanced dataset frameworks for evaluation of these kind of problems, essentially, and most of them talk about using precision and recall in both RSC curve and AUC, pretty standard in machine learning. But I thought that it would be interesting to see how it translated to a ensembled model. Ensembled essentially meaning combining all the outputs and the power of these models into one. Even though each of them took around 6 hours for a single run, and we're talking about at least 10 to 20 runs here. But the combined output surprisingly didn't have as much of an effect because, as we probably previously discussed with my supervisor, the fact that they are modeling different aspects of patients and taking into consideration and predicting some patients better than others would have theoretically provided a better approach to the combine. So theoretically, combining them would have made a better approach to detecting sepsis, but actually noted that there were a very slight improvement in the scores. So currently in research, what we're finding, the highest utility scores to be 0.45. So we are not far from them. We're at 0.36 with our utility score and around 30 minutes per epoch. Um, and I'm understanding that the actual layers we trained within the ensemble didn't really provide as much training parameters. So there was no means of improving the decision taken by the rest of the models there. But to take it back a step, the focus of our research is to understand the underlying decisions that this algorithm is taking and how much weightage it's putting on each of these clinical parameters. Now, the inherently we noticed that the algorithm was performing as it suggested, and it was performing against as expected, essentially against clinical criteria. So some things we realized were that as the ICU length of stay got longer, we realized that that algorithm was more prone to detecting sepsis at the end. And imagine that longer ICU stays usually infer a deterioration in the patient's condition. FiO2 scores too indicated sepsis diagnosis, as the oxygen concentration in the air was very important to our patients to allow them to actually get the highest possible oxygen throughput into their organs from outside into their organs. And if they were put on respiratory systems, it would have probably been evident that they might be suffering from an infection of sorts or virus. The temperature, which was related to the immune system reacting to the bacterial infection, PEA, CO2, as well as bilirubin are both part of the SOFA score, so it's the sequential organ failure assessment score. And one models the respiratory system and how well it's performing and how prone it is to failing. One models the kidney and how well it's performing and how prone it is to failing. And we thought that even after the not so great results, I'll put it this way, we thought that we would take it one step further, as Neil Armstrong did. And I introduce a completely novel approach to actually detecting sepsis. There is no prior techniques being applied to this data set in terms of reinforcement learning, and there is a huge lack of this kind of machine learning technique in healthcare data. What it is simply is reinforcement learning is an experience-based learner. So you imagine a game. If the objects of the game is to climb a mountain, the only way that person is going to be able to climb the mountain is by interacting with the environment. What I mean by this is the algorithm will understand the position and the velocity that person's going at, and it will just try and fail, try and fail, try and fail until it reaches that goal. And when it reaches that goal, it rewards the algorithm. And after a while, the algorithm understands that it has to seek that higher reward, and it starts getting to that goal faster. So some of the ways that reinforcement learning has been applied in healthcare has been to model sepsis treatment. So Patients' SOFA scores are modeled. When the SOFA score deteriorates, a treatment is given to the patient. The outcome of that treatment is essentially monitored. And if the treatment is successful, the algorithm's reward. If it's not, it's penalized, and then another treatment is given. Many of this resembles the same clinical trial dosing regime. So, how much of a dose are we supposed to give, and how much is effective, and how much causes a reward or a penalization. There's also other algorithms that encourage physical activity in diabetes patients. So, trying to encourage them to get up and go out by looking at their state and how they evolve and how much activity they do. But in our scenario, our environment essentially is a patient sitting in an ICU, and there's a doctor, which is our actor, essentially in this case, and there is an evaluator at the other end. Let's put another doctor, and the evaluator is criticizing the actual decision that the actor has taken. So the actor could be a pre-med student, I think, doing his clinical practice, let's say. And then the critic could be the actual doctor in this case. So we'll take this data, all the same data that we've been using. We will read in windows of 6 hours, essentially take the first 6 hours of the patient. We will predict from that using our underlying LSTM algorithm as we did in our initial work. This time, we're only predicting a single diagnosis after those 6 hours. And then what will happen is with that predicted outcome, um, we will find ourselves in a situation where we want to understand if that predicted outcome is the same as the actual outcome of the data after those 6 hours, outcome of the patient after those 6 hours. So what we will move to do is to reward or penalize the algorithm. So on top of the fact that we have an LSTM, which is the previously stated has already been shown to be capable of learning to diagnose this condition, we have a machine learning algorithm which is rewarding and penalizing the correct or wrong instances where the algorithm has actually made a mistake. So we term this as self-learning. But essentially, we want to model the way we reward the algorithm the best we can to. So one of the ways we've done it is a probability-based reward. So how close is it to a 50-50% chance? If it's not that close and it's correct, then we'll reward it highly. If it's very close and it's wrong, we don't want to reward it highly. We want to push it away. But we also want to take in consideration that there's an aspect of sepsis that is timely. We want to know the best, we want to know the diagnosis 6 hours earlier to the actual diagnosis. So we want to be able to predict those 6 hours with the sepsis diagnosis that the patient initially started without and ended up with. So we model that with a utility-based reward to the same as the clinical utility function for evaluation, but converted into a reward function. Um, but we don't only see that patients have, we don't only understand that patients have the 6 hours of data. We understand that some patients come in with 96 hours, with 330 hours. So what we do is this window of 6 hours moves one time step across to the 7th hour, looks back 6 hours, and then tries to predict that 7th hour's diagnosis. And we do that across the whole data set, taking one step at a time until it's completed the full data set of that patient. Once we've completed that whole patient, we move to what is criticizing the decision. Essentially, you'll have one set, which will be the initial uh, 6 hours combined with the whole rest of the patient. And you'll have another data set, which is one time step forward from the actual data set. Both of those data sets will be modeled and predicted will be modeled by another LSTM, a critiquing LSTM, and they will both output probabilities for each of those hours of the diagnosis. And then what we do with those two sets of probabilities is we calculate how much of an advantage has the algorithm actually gained over time. So how much has that decision improved from the initial time step to the next time step? And how much has that algorithm learned? So we use this advantage parameter from the critic algorithm, and we take that and feed it back into the actor algorithm, which is the one actually taking the steps and predicting each moment, each 6 hours, so that the actor algorithm can understand how to better model this patient and how to take the next steps so that it converges to the best set of weights. And yeah, so in conclusion, what we're currently doing is training these actor critic reinforcement learning algorithms. And right now it's behaving like a teenager. So it's very moody, doesn't like sepsis at all, thinks everyone is sepsis or no one is sepsis. So it's generally a problem of overfitting on the data set. But we're improving the metrics and reframing the workflow of our data and how we put it, feed it into the actual algorithm. And we're hopeful that it will improve. But generally, what my aims are for this project is to showcase some imbalancing techniques and basically publish some literature on actual effective techniques to mimic the lack of data in rare diseases, and also create this explainable interface. So as I mentioned before, the QSOFA score is a quick SOFA version of the actual SOFA score, and it just provides a very hourly instance of how the patient is actually doing. And what we've tried to do with this model view of plots is essentially showcase how the interface would be in a real clinical scenario in an ICU, and how the heart rate varies, the respiration rate varies, and how the patient develops sepsis after it turns yellow. So just a way to formulate that more explainable interface for what sets of markers might be important to the patient's diagnosis. And our future projects are working with Cardiff Heath Hospital to look at secondary healthcare data, so modeling cardiac patients which manifest cardiac symptoms which may be indicative of a rare disease. So looking at them and how their cardiac biomarkers vary and which ones are more suspicious and yet to a diagnosis. With the SAIL, we're looking at how patients in primary care often manifest a series of symptoms which could be indicative of or could inherently lead to a suspicion of Fabry. But yeah, that's most of it. And yeah, I'm open to questions.